This episode is brought to you by Starbucks.
That is fire.
Whoa, that's good.
This might be the drink of the summer.
Okay, I like this one too. I'm rocking with it. Okay.
Try it for yourself. Starbucks Refreshers concentrates are coming home. Find them in the coffee aisle and make it yours.
Choice Hotels get you more of what you value. Comfort Inn, it's calling your name. Save on the stay. Oh, and free waffles are yours to claim. Book direct at choicehotels.com.
Hey everyone, Chris here from MedPrep2Go, and welcome to another episode of our USMLE Step 2 Questions podcast. In this episode, I'll be reading 3 more ENT questions from our online Qbank, and as always, you can read these questions and more at medprep2go.com. And now, let's get started with question 1, ENT7. A 6-year-old boy is brought to the emergency department with fever, worsening left ear pain, and swelling behind the ear for the past day. He was treated 10 days ago with oral antibiotics for acute otis media, but continued to have intermittent fevers. Past medical history is otherwise negative. His temperature is 39.2 degrees Celsius, or 102.6 degrees Fahrenheit, and his other vital signs are within normal limits. On physical examination, the left post-auricle area is erythematous, tender, and swollen, with protrusion of the auricle. Otoscope examination reveals a bulging erythematous tympanic membrane with purulent material. Which of the following is the most appropriate next step in management? Is it A, CT scan of the temporal bone? B, high-dose intravenous antibiotics with otolaryngology consultation? C, oral amoxicillin clavulanate therapy? D, reassurance and outpatient follow-up? Or E, tympanostomy tube placement alone? And the correct answer is B, high-dose intravenous antibiotics with otolaryngology consultation. This child's presentation is consistent with acute mastoiditis, a serious complication of acute otis media caused by spread of infection into the mastoid air cells. Key findings include post-auricle swelling and erythema, protrusion of the auricle, persistent fever, and otoscopic evidence of middle ear infection despite prior antibiotic therapy. Management requires hospital admission, prompt initiation of high-dose antibiotics, and urgent otolaryngology consultation. Surgical intervention may be required if there is abscess formation or failure to improve with antibiotics. Answer choice A, CT scan of the temporal bone, is incorrect. Although CT imaging may be useful to assess for complications such as abscess or intracranial extension, treatment should not be delayed when clinical findings are classic for mastoiditis. Answer choice C, oral amoxicillin clavulanate therapy, is incorrect. Oral antibiotics are inadequate for mastoiditis, which requires intravenous therapy due to the risk of rapid progression and intracranial spread. Answer choice D, reassurance and outpatient follow-up, is incorrect. Mastoiditis is a potentially life-threatening condition and cannot be managed expectantly. Answer choice E, tympanostomy tube placement alone, is incorrect. While tympanostomy tubes may help with drainage, they are not sufficient as monotherapy for an established mastoid infection. Key learning point. Mastoiditis is a complication of acute otis media characterized by post-auricle swelling and auricle protrusion. Management requires urgent intravenous antibiotics and otolaryngology consultation. Question 2, ENT8. A 27-year-old woman presents to the clinic with 3 days of worsening right ear pain. She reports recent swimming during a vacation and notes that the pain is severe when she touches or pulls on her ear. She denies fever, hearing loss, or upper respiratory symptoms. Past medical history is negative. Physical examination reveals tenderness with manipulation of the tragus and pinna. Otoscopic examination shows an edematous, erythematous external auditory canal with scant debris. The tympanic membrane is intact and appears normal. Which of the following is the most appropriate initial treatment for this patient? Is it A, oral ciprofloxacin therapy, B, topical antibiotic eardrops, C, topical corticosteroids alone, D, tympanostomy tube placement, or E, urgent CT scan of the temporal bone? And the correct answer is B, topical antibiotic eardrops. This patient has acute otis externa, commonly known as swimmer's ear, which is an infection of the external auditory canal. It is typically caused by Pseudomonas aeruginosa, or Staphylococcus aureus, and is associated with water exposure. Hallmark features include ear pain that worsens with manipulation of the tragus or pinna, an edematous and erythematous ear canal, and an intact tympanic membrane. First-line treatment for uncomplicated otis externa consists of topical therapy, such as acetic acid drops or topical antibiotic drops, often combined with corticosteroids to reduce inflammation. Answer choice A, oral ciprofloxacin therapy, is incorrect. Systemic antibiotics are not indicated for uncomplicated otis externa and are reserved for severe or invasive infections such as malignant otis externa. Answer choice C, topical corticosteroids alone, is incorrect. Corticosteroids may reduce inflammation but do not treat the underlying infection when used alone. Answer choice D, tympanostomy tube placement, is incorrect. Tympanostomy tubes are used for recurrent or chronic otis media, not infections of the external auditory canal. Answer choice E, urgent CT scan of the temporal bone, is incorrect. Imaging is not necessary for uncomplicated otis externa and is reserved for suspected malignant otis externa or complications. Key learning point. Otis externa presents with ear pain worsened by tragus or pinna manipulation and is treated first line with topical acidifying or antibiotic ear drops. Question 3, ENT 9. A 32-year-old man presents to the clinic with progressive left-sided hearing loss and chronic foul-smelling ear drainage for the past 6 months. He reports a history of recurrent ear infections during childhood. Otoscopic examination reveals a retracted tympanic membrane with a pearly white mass in the upper portion of the middle ear and keratin debris within the external canal. Audiometry demonstrates conductive hearing loss in the left ear. Which of the following is the most appropriate next step in management? Is it A, high-dose oral amoxicillin therapy? B, intratympanic corticosteroid injection? C, surgical excision of the lesion? D, topical antibiotic eardrops alone? Or E, watchful waiting with serial audiometry? And the correct answer is C, surgical excision of the lesion. This patient's presentation is consistent with cholesteatoma, an abnormal collection of keratinizing squamous epithelium within the middle ear that can result from chronic eustachian tube dysfunction and tympanic membrane retraction. Patients typically present with chronic foul-smelling otorrhea and progressive conductive hearing loss. On otoscopy, a pearly white mass may be seen behind a retracted tympanic membrane. Cholesteatomas are locally destructive and can erode ossicles, mastoid air cells, and adjacent structures, leading to complications such as facial nerve palsy, labyrinthitis, or intracranial infection. Definitive management requires surgical removal. Answer choice A, high-dose oral amoxicillin therapy, is incorrect. Although secondary infections may occur, antibiotics do not eliminate the keratinizing epithelial mass and are not definitive treatment. Answer choice B, intratympanic corticosteroid injection, is incorrect. Steroids are used for conditions such as sudden sensorineural hearing loss, not for cholesteatoma. Answer choice C, topical antibiotic eardrops alone, is incorrect. Topical therapy may reduce drainage, but does not address the underlying destructive lesion. Answer choice E, watchful waiting with serial audiometry, is incorrect. Observation is inappropriate due to the risk of progressive bone destruction and serious complications. Key learning point. Cholesteatoma presents with chronic foul-smelling otorrhea and conductive hearing loss that requires surgical excision due to its locally destructive nature. And that will conclude this episode of our USMLE Step 2 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrep2Go on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 2 questions at medprep2go.com. Happy studying! Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics. Hey everyone, Chris here from MedPrep2Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 questions podcast combined and ad-free. You'll also get early access to all of our Step 2 questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com.